Hi guys, welcome back to week 14, final week of PowerPoint presentations. I'm so proud of you guys for making it this far. I know this is a hard class. I know it's a lot of material to learn and it can be very overwhelming at times, but I'm confident just based on around all of your response papers that you guys really understood the depth of this class and the importance of really grasping how complicated the body and its system is. So I'm really proud of all of you. For this week, we focused on renal and genitourinary. So I just want to get into that really quickly so I can go through this just to make sure to highlight some key points that I wanted to make sure to review with you guys. So, we'll bring it back to the basics as usual. We start with that. Just make sure you do a really good review of your kidney structure and function. Make sure you really look at all of your anatomical parts of the urinary system, including the anatomy of the nephron. In this chapter, they really went into the kidney and homeostasis and how the kidney maintains homeostasis in terms of the kidney structure and function. It's very important that you understand the kidney's ability to remove metabolic waste products and metabolize drugs. Please just also make sure you review and understand the role of the natriuretic peptide and its effect on kidney regulation. Some other key points that I wanted to just make sure is that you really make sure you review that the kidneys have several functions that contribute to homeostasis, but the primary role of the kidney is to maintain fluid and electrolyte balance over a wide range of states and take electrolytes and stimulate red blood cell production as well. It also has a role in activation of vitamin D and the production of renin. And keep in mind, in terms of understanding the overall structure and function of the kidney, that the body is 50 to 60% of water, and depending on the sex, age, and body composition of your patients, through the patient's kidneys, they regulate the amount of body water as well as its composition. And like I said here, just make sure you review the nephron anatomy because make sure it's very important to remember that the functional unit of the kidney is the nephron and that each kidney contains about 1 million nephrons. There is a considerable functional reserve, and that is why someone with healthy kidney function can donate a kidney and still maintain a normal kidney function. Remember, we actually only really require one kidney. The kidney in general receives a far greater blood flow than its size and weight would actually dictate. So the kidney actually receives about 20% of cardiac output. So again, I just want to make sure I reiterate that you make sure you understand in terms of the function of kidneys, the functions of the kidneys are carried out by the nephrons. So keep in mind too that each kidney has up to 1 million nephrons at birth, but no additional nephrons are added after birth. So if a baby is born prematurely, there is a gross restriction during gestation, which can actually decrease the nephron number. And the excess capacity or renal reserve presented by the large number of nephrons is the basis of a healthy person's ability to donate a kidney without actually developing kidney failure. Another thing to make sure you're reviewing is how kidneys remove metabolic waste products and metabolize drugs. You have to remember that many metabolic waste products and toxins and neurotransmitter hormones, as well as drugs that are filtered at the glomerulus and are not reabsorbed. So they are excreted in the urine. And some of the substances are also secreted by the proximal tubular organic anion and cation transporters, and further enriching their concentrations in the urine and providing faster clearance, which can be achieved by filtration alone. And filtration can be done for substances that travel in circulation, which are bound to plasma proteins. They are protected from glomerular filtration, but they can still be excreted by the process of tubular secretion. So I know that's a lot. So just in general, I wanted to review that in a quick video, but like 3-4 minutes. So just watch this. It's a very basic visual review of kidney structure and function. 7 minutes. Here we go.
The urinary or excretory system, is another system by which the body rids itself of unwanted toxins or waste. Basically, the urinary system's main purpose is to maintain the body's homeostasis. In other words, its main function is to maintain the body's acid-base balance. It's important to know the human organism was meant to stay healthy, and systems such as the urinary, digestive, skin, and other vital organ systems were created for that purpose. They are designed to keep the body healthy and able to withstand diseases. But if the load of toxins and or waste is greater than what these systems can handle, guess what happens? You can learn more about this by watching CTE Skills Introduction to the Cell and see how disease is created. In this introductory video on the urinary system, however, we'll just be taking a look at the purpose of the urinary system, the structures that make it up, the functions of each, and how they work together to maintain balance in the body. The urinary system, much like the integumentary system, doesn't have many parts, but they are truly essential to the survival of the human organism. Let's take a look at the basic anatomical structures of the urinary system. They are 2 kidneys, 2 ureters, 1 bladder, 1 urethra, and the urethra meatus. Now the 2 kidneys are bean-shaped in appearance. They are located on either side of the vertebral column behind the upper part of the abdominal cavity. The kidneys are protected by the ribs and a heavy cushion of fat called the adipose capsule. They are literally suspended in the body, meaning unattached to any other major organ. They pretty much stay up by themselves. And for this reason, kidney punching in boxing is illegal. Each kidney is divided into 2 main sections, the cortex and the medulla. The cortex is the outer section of the kidney. It contains the majority of nephrons. Nephrons are microscopic filtering units. These filtering units are composed of the following structures: a glomerulus, a Bowman's capsule, a proximal convoluted tubule, and a distal convoluted tubule, and a collecting duct. Together, these structures purify the blood by removing excess water, salt, sugar, metabolic products, and other substances the body needs to purge in order to maintain the pH acid-base balance and thus the homeostasis of the body. Now, the medulla is the intersection of the kidney. It contains most of the collecting tubules, which carry the urine from the nephrons through the kidney to the ureters. The ureters are 2 muscular tubes, approximately 10 to 12 inches long, and extending from the renal pelvis of each kidney to the bladder. Now, the bladder is a hollow sac, much like the stomach, lined by a series of folds called ruga. The purpose of these folds is to allow the bladder to expand as urine is collected. The bladder typically holds up to 1 cup of urine, and sometimes more, until the urge to void or urinate is turned on. From the bladder is the urethra.
It's 11 o'clock.
Its job is to carry the urine from the bladder to the outside of the body. The last structure in the urinary pathway of purging toxins from the body is the external opening to the urethra. This is called the urethra meatus. Now, here's a very important note to make about the urethra and the sexes. In females, the urethra is only about 1.5 inches long, and it is separate from the reproductive system. While in the males, the urethra is approximately 8 inches long, and before the urine exits, it goes through the prostate gland. The urethra in the male is used by 2 body systems, the urinary and the reproductive. Only urine passes through the urethra in the urinary system, but in the reproductive system, only semen passes through. Urine and semen will never pass at the same time through the male's urethra. So what exactly is urine? Urine is the waste product that the urinary system is responsible for eliminating from the body. It's 95% water, and the other 5% is made up of urea, uric acid, creatine, mineral salts, various pigments, and sugar. Excess sugar found in the urine can be indicative of diabetes. In a day's work, the kidney can filter up to 150 quarts of liquid, resulting in about 1.5 to 2 quarts of urine. That's if you're drinking the proper amount of water. Last but not least, each of the kidneys have the adrenal glands attached to the upper portion. These glands have very important functions that will be explained in the endocrine system. Now, before we finish, let's go over it one more time. The basic purpose for this system is to cleanse the blood. It filters out toxins such as excess sugars and salts, as well as other substances. The main structures or anatomical parts are 2 kidneys, 2 ureters, 1 bladder, 1 urethra, and the urethra meatus. Each kidney is divided into the cortex and medulla. Inside the cortex of both kidneys are thousands of microscopic filtering units called nephrons. And remember, it's important to drink lots of water in order for the kidneys and the urinary system to continue to function properly. Thanks for watching. For more videos on the urinary system, visit cteskills.com.
All right, guys, hopefully that was helpful. I just really like their very basic breakdown of everything to just put all of this in perspective. Okay, just some pearls as reminders. The urinary system, you can identify the kidneys by the word renal or the prefix nepher, and the bladder by the prefixes cysto and vesico. Remember, diabetes is associated with glomerulonephritis, and hypertension is associated with polycystic kidney disease. Okay, concepts in fluid, electrolyte, and acid-base balance. So here I really want to make sure that you understand hypertension, the causes and the effect on the function of the nephrons, the risk factors, and the effect on glomerular filtration, as well as the treatments. Okay. Also keep in mind the human body consists of 2 kidneys, as they said in that video. Each kidney contains millions of filtering units, which we have learned so far as nephrons. Nephrons include a filter called the glomerulus and tubule. The glomerulus is responsible for filtering excess fluid and toxins from the blood, and the tubule returns the required minerals and nutrients back to circulation. Excess fluid and waste excreted from the body is urine. So in chronic kidney disease, or CKD, this condition is in which the kidneys are damaged and can no longer filter blood adequately as a result of the excess fluid and waste buildup in the blood, which ends up disrupting homeostasis and increasing the incidence of additional health issues such as cardiac disease or stroke. The key point that I want you to remember is that the glomerulus is the primary site of injury in patients with diabetes and hypertension, although the disease progression later extends to the tubular dysfunction later on. Another key concept I wanted to review is just to make sure that you reviewed the mediators that alter renal, electrolyte, and water transport to maintain systemic homeostasis. So the mediators that have this can alter renal, electrolyte, and water transport and have a major impact on systemic homeostasis include aldosterone, arginine vasopressin, nitric peptides, and parathyroid hormones. Again, please review these mediators. Again, I'll repeat the mediators. So we have aldosterone, arginine vasopressin, nitric peptides, and parathyroid hormones. Okay, so just to do a quick, literally 3-minute quick acid-base balance review, I just want to make sure you guys are still up to par with that. I know if you're not really doing this in practice or having to utilize this information in practice, then you kind of tend to forget it. So just watch this review. It's 5, 6 minutes just to go over the acid base balance.
pH is an indicator of acidity. The body's blood pH
Remember,
is
your
strictly
pH
regulated
really
within a
is
narrow range between 7.35
what helps
and
maintain homeostasis.
7.45. This is because even a minor change in acidity may have devastating effects on protein stability and biochemical processes. Normal cellular metabolism constantly produces and excretes carbon dioxide into the blood. Carbon dioxide combines with water to make carbonic acid, which dissociates into hydrogen ions and bicarbonate. This is an equilibrium, meaning all of the components of the left and right sides coexist at all times, and the concentration of any component is determined by that of others at any given moment. The rule of thumb is an increase in concentration of any component on one side will shift the equation to the other side, leading to increased concentrations of all components on that side, and vice versa. This equilibrium is central to understand acid-base regulation. Continued carbon dioxide production by all cells of the body drives the equilibrium to the right to generate more hydrogen ions. Because pH is basically a function of hydrogen ion concentration, more hydrogen means higher acidity and lower pH. Normal metabolism, therefore, constantly makes the blood more acidic. The body must react to keep the blood pH within the normal limits. This is achieved by two mechanisms: elimination of carbon dioxide through exhalation. The amount of carbon dioxide exhaled by the lungs is regulated in response to changes in acidity. A decrease in pH is sensed by central or arterial chemoreceptors and leads to deeper, faster breathing. More carbon dioxide is exhaled, less hydrogen is made, blood acidity decreases, and blood pH returns to normal. Pulmonary regulation is fast, usually effective within minutes to hours. Excretion of hydrogen ions and reabsorption of bicarbonate through the kidneys. The kidneys control blood pH by adjusting the amount of excreted acids and reabsorbed bicarbonate. Renal regulation is slower. It usually takes days to respond to pH disturbances. Although all of the plasma bicarbonate is filtered in the glomerulus during the first step of urine formation, virtually all of it is reabsorbed back into the blood. Most of this reabsorption happens in the proximal tubule. The amount of reabsorbed bicarbonate in the proximal tubule is regulated via a number of mechanisms in response to changes in blood pH. It increases during acid loads and decreases during alkali loads. While the proximal tubule basically returns filtered bicarbonate back to the blood, the downstream collecting duct generates new bicarbonate by actively secreting acids. As protons are depleted from the distal tubular cells, the equation shifts to the right, producing more bicarbonate, which then exits into the blood. Hydrogen ions secreted into the lumen combine with urinary buffers, mainly filtered phosphate and ammonia, to be excreted in urine. The ammonia buffering system is particularly important because, unlike phosphate, which is filtered in fixed amounts from the plasma and can be depleted during high acid loads, ammonia production is regulated in response to changes in acidity, and its concentration may increase several-fold when necessary. Blood pH is the main regulator of acid excretion, but potassium, chloride concentrations, and several hormones also play important roles. Pathologic changes may cause acid-base disturbances. Acidosis refers to a process that causes increased acidity, while alkalosis refers to one that causes increased alkalinity. It's not uncommon for a patient to have several processes going on at once, some of them in opposite directions. The resulting plasma pH may be normal, too acidic, called acidemia, or too basic, called alkalemia. Acidosis may result from inadequate function of the lungs, which causes arterial carbon dioxide to accumulate. This is respiratory acidosis. On the other hand, metabolic acidosis may result from excessive production of metabolic acids, ingestion of acids, decreased ability of the kidneys to excrete acids, or loss of alkali. Metabolic acidosis is characterized by primary decrease in plasma bicarbonate. Alkalosis can also be either respiratory or metabolic. Respiratory alkalosis is caused by increased ventilation, resulting in excessive exhalation of carbon dioxide. Metabolic alkalosis can result from excess loss of acids through the kidneys or gastrointestinal tract, bicarbonate retention, or ingestion of alkali. Metabolic alkalosis is characterized by primary increase in plasma bicarbonate.
Hopefully
Thank you
this
for
was really
watching.
helpful for you
Please
guys.
feel
Just to really reinforce, how acid base and electrolyte imbalance can affect the homeostasis and where the kidneys fall in that role. Okay, acute kidney injury and chronic kidney disease continuum. So one leads to another. That's why we're looking at it from a continuum of disease. Key points that I wanted to point out here is understanding, what kidney injury is, the clinical manifestations, and the important diagnostic findings that you would be making sure to check on for your high-risk patients. I really need you to understand and review diabetic nephropathy as well, the pathophysiology, the clinical manifestations, and the treatment, and understand the differences in terms of acute kidney versus chronic kidney injury. As a review, diabetes mellitus is the most common cause of chronic kidney disease, as elevated blood glucose levels adversely affect the proteins of the glomerulus, in addition to increasing the tubular glucose, which promotes hyperfiltration, placing more stress on the glomerulus over time. This leads to a loss of glomerular function and the pathological presentation of global glomerulosclerosis. So glomerulosclerosis is the scarring and loss of surface area on the glomerular capillaries. As glomerular function is depleted, tubular atrophy occurs, and tubular atrophy is a process in which the tubule cells undergo apoptosis, or cell death, as the nephrons die. Interstitial fibrosis occurs in which fibrotic tissue replaces some of the kidney tissues. Diagnostics that are important for you to review are included in any patient with suspected kidney disease, which includes testing the blood in the urine, or testing the blood in urine. The primary signs of kidney dysfunction include increased levels of blood urea nitrogen, or BUN, goes up, and creatinine. Remember, creatinine is normally present in the blood, but due to the kidneys continuously removing it through filtration and tubular secretion, sometimes it will build up. So therefore, the renal clearance for creatinine is determined by the glomerular filtration rate. When the GFR decreases due to acute or chronic kidney dysfunction, the creatinine levels will increase in the blood. So serum creatinine levels are used to estimate GFR by utilizing equations that include the patient's age, sex, body size, and ethnic ancestral descent. Keep in mind, you need to know how to calculate the GFR, but there are GFR calculators that you can download onto your phone, and I highly recommend you do this. At the end of this PowerPoint, there is a link. There's actually numerous links for more information about kidney, or just sites to go on for evidence-based information regarding kidney disease. And on that list, there is a link for a GFR calculator that you can download. Another thing to keep in mind is that many medications are cleared by the kidneys, and a decrease in the GFR will result in a delayed drug clearance and an increased probability of toxic levels of medication that will build up in the blood. So please review how the CKD diagnosis is categorized. Remember, CKD staging criteria is based on the patient's GFR and then is categorized into 5 stages. So please review the 5 stages of CKD. As a review, stages 1 through 3 are often asymptomatic. Symptoms usually start in stages 4 and 5. And remember, stage 5 is the worst, as that is end-stage renal disease. Remember, symptoms later in CKD and in later stages of CKD include nausea, vomiting, decreased appetite, fatigue, weakness, swelling, shortness of breath, as well as pulmonary edema, which ends up leading to systemic overload. Again, another key point to remember is that GFR and ACR are the tests used to diagnose end-stage kidney disease. Okay. Gerontological considerations. So in terms of these considerations, you definitely need to make sure you review the age-related changes that come with the kidney. Unfortunately, as most diseases, as you age, things do not get better. So it's very important to make sure you know how to measure the GFR. Again, you can download the GFR calculator. Just keep in mind, GFR is most often calculated based on the creatinine levels in the blood. There are several formulas that can be used when considering the GFR, but again, most of them consist of the age, body size, and gender, along with blood creatinine levels to calculate the kidney function. Creatinine clearance is based on a 24-hour urine collection, which is also another way to estimate GFR. Formula-based measurements of a GFR or MGFR both require invasive procedures in a nephrology lab and are considered the gold standard of GFR measurement. Another key thing to make sure you realize is that the age-related changes on medication absorption and risk for toxicity in terms of gerontological considerations. Older adults have progressive renal tissue alterations, including loss of nephrons with glomerulosclerosis. They also have progressive reductions in estimated and measured GFR that may not be proportional to the histologic changes that are associated with sarcopenia and advanced age. Creatinine production also decreases, and it's not certain whether current estimating equations for GFR are from serum creatinine accurately reflect the actual GFR in older adults. In terms of treatment of chronic kidney disease, it depends on the severity of the disease. And this is something you need to consider in terms of your gerontological population, because they are all going to be at different levels. CKD can be managed by addressing the modifiable risk factors and adhering to prescribed medication regimens. Commonly used in treating chronic kidney disease includes dietary supplements, iron therapy, diuretics, vitamin D replacement. And then in later stages of CKD, food and electrolyte imbalance usually gets progressively worse, and it requires the patient to go for regular dialysis treatments in order to survive. Unfortunately, in terms of gerontological considerations, the only cure for CKD is really to undergo a kidney transplant. Okay, pediatric disorders of the urinary tract, and kidneys. So the main things I wanted to just really reinforce is that you have to remember that nephron development is complete by 36 weeks age of gestation. So again, I'll reinforce this, that prematurity and low birth weight are associated with reduced nephron numbers at birth, and may predispose the patients to development of hypertension and kidney disease later in life. Pediatric urinary disorders include both malformations of urogenital structures and abnormalities of the nephron function. There's minimal change disease, often has pediatric onset and results in nephrotic syndrome. So definitely make sure you review acute kidney injury in the pediatric population, as well as the pediatric genetic disorder polycystic kidney disease. And here is just a diagram of what it looks like both externally and internally polycystic. It's not pretty. Okay, so here are your additional resources if you had any questions. Again, keep in mind you guys are in grad school. One of the biggest things I had to learn in grad school was, number one, the importance of your own ability to learn and your drive to understand things and really take initiative in learning for your own, for your own sake, for your patient's sake as well, but it is your profession now. And in grad school, there's no more hand holding, there's no more coddling. It's really up to you because we are preparing you for real life. Keep in mind, when you're on the floor and you're in practice, there is no time and there is no room for anybody to be holding your hand. When you need to make a move or a decision or a diagnosis, you got to do it, and you need to make sure you have the right resources. And one of the biggest things you're going to learn in grad school is that is what you are learning. You are learning how much information is out there and where to find the right information that's evidence-based. And that's one of the biggest things I want you to realize, that we are giving you all these resources, all this information, and just try to file it away, if not in your head, but on your phone, in your notes, whatever you want to do, but just make a system where you can always go back to these tools when you're in practice quickly, have access to it so you know where to go for certain things, whether it's a GFR calculator, whether it's the CDC for immunizations, whether it's the US task force for the current primary care guidelines. These are all things to keep in mind that you need to make sure you are aware of these resources and make sure you document from them to validate the diagnostics that you come up with for whatever you're dealing with. All right, guys, thank you and good luck. There is a posted study guide for the exam. Please do yourself a favor, follow that guide closely, make a study guide to go with it, and I can really guarantee that that will bring you great success. Thank you so much and have a great summer.